It's Friday, March 21, a rainy, gray spring day in Vancouver, BC. I'm here in New Westminster. I just got off the SkyTrain and I'm walking a couple of blocks to the Umbrella Multicultural Co-op Clinic, where I'm going to be meeting the team to hear more about how it is that they serve newcomers here in Canada. Umbrella is in an urban area of New Westminster that's home to many small ethnic shops and service centers on a long, sloping street. I see a Vietnamese restaurant, a nail spa, a barbershop, passing a Bami bar, a vintage clothing store, an indigenous art store, and here we are. From the street, the Umbrella Multicultural Co-op Clinic looks pretty nondescript. It takes up about 3 storefronts with shaded windows and a simple vinyl logo graphic on the middle storefront window.
Hi, come on in. Do you want to wipe off your glass? I know.
Yeah. Classic Vancouver.
Yeah,
Let me the risk of not taking my umbrella.
Yeah, you're just I need those windshield wiper glasses.
Inside the clinic, I'm met by Dr. Mei-Ling Weidmeyer and Naomi Armstrong, who give me a tour of Umbrella.
I'm Mei-Ling Weidmeyer. I'm a family physician, and I work here as both a family physician and also as the clinical lead. So I provide a little bit of direction and leadership around the clinical care and planning for our service.
So my name is Naomi Armstrong. My title here is the Director of Integrated Health Programs. So try to support most of the programs we have here. So I don't have a clinical background, but public health, health equity, and kind of non-profit management.
I first connected with Mei-Ling and Naomi because Umbrella was part of the Our Care roundtables, and it struck me that the way they approached care for newcomers exemplified 3 of the 6 Our Care standard elements. Their team provides culturally safe care that supports overall well-being by addressing social determinants of health, and ultimately is accountable to the communities it serves. At Umbrella, they have registered patients who receive primary care, including mental health services, but they also have a health promotion program that serves anyone in the community, whether or not they receive primary care at the clinic. And they have services for migrant workers. This last group is a unique underserved population, and serving them is really at the foundation of how this clinic came to be. And so today, we're in Vancouver to tour a clinic that started in a rental trailer, but now routinely serves patients in 5 different languages, with a team that's deeply integrated into the community. Welcome to Primary Focus. I'm Dr. Tara Kiran, and I'm on a journey to bring you stories from innovative clinics across Canada that are offering primary care that meets the Our Care standard, a set of principles that define what every person in Canada should expect from the primary care system. If you listen to our episodes on Costa Rica, you'll know that we focused on the role of the community health worker, who acts as a link between the primary care clinic and the broader community it serves. There are some examples of similar roles here in Canada that help connect primary care with community. But at Umbrella, they've developed a role that's unique, the cross-cultural health broker. To understand how this came to be, we need to go back to that origin story and finish our tour. After that, I'll sit down with Mei-Ling for a conversation about her experience working at Umbrella. I'd love to hear more about how Umbrella started up. This is Naomi.
So we were sort of hosted in the beginning by another nonprofit organization and originated as a co-op, right? So really with the idea that healthcare decisions of newcomer migrant communities should be guided by those communities themselves, not a top-down model.
One important thing to note about Umbrella is that it was built under a healthcare cooperative model. That means 80% of board members must be from the community it serves, and those board members play a direct and structured role in its governance and decision-making.
So there was a group of initial board members, all of whom self-identified as having had language or cultural barriers to accessing healthcare. So they formed the initial board back in 2010 as a co-op. We started with really tiny programs. So we had the mobile primary care clinic for migrant farm workers with some grant funding. And we had some very small health promotion programs.
Vancouver is one of Canada's most diverse cities. According to the 2021 census, Vancouverites identified with 244 different cultural origins, and half of the residents reported they were born outside of Canada. We know that across Canada, newcomers often struggle to get access to primary care. And there are clear reasons why. I mean, finding a family doctor, it's hard enough for everyone. But can you imagine if you don't have documentation, or maybe you don't even know what primary care is because primary care and family doctors didn't actually exist in your country, or you don't speak fluent English? Imagine how tough it is to navigate the system we have. Even communicating with a doctor can be a challenge. As an aside, I should say that I'm using the term newcomer as a catch-all for different groups. Immigrants, refugees, migrant workers. Each has a distinct origin story, but they all face challenges here in Canada accessing primary care. And those challenges, they actually can extend years after they've arrived. So when I say Umbrella serves newcomers, some of the people that they serve have actually been in Canada for over a decade, but they still have challenges that require the support of Umbrella. And while Umbrella now serves many different groups of newcomers to Canada, it all started with migrant farm workers. I think it's fair to say that most of us in Canada were not really aware of migrant farm workers and their role in the agricultural system in our country. One reason for that is that most people don't see or interact with migrant farm workers. These are workers from Mexico, the Caribbean, and Central America who come to Canada seasonally on closed work permits. That means they can only work for the employer who sponsors them. And they usually live on site in very rural locations that lack public transportation. On top of that, many are Spanish-speaking. And while they're now eligible for provincial health insurance in BC, after a 3-month wait period, that doesn't always mean that they're signed up for it. Back in 2010, they only had access to private health insurance, which wasn't always accepted in nearby clinics, if they could actually get to those clinics. And so Umbrella started up as a mobile pop-up clinic to serve these migrant farm workers. Naomi says when Umbrella started, they did have a small room in a local community health center that they were given for free, but to provide care to migrant workers, they had to go to them.
Back then, we used to rent U-Haul trucks and set up the clinic in the back of the U-Haul truck every time in different locations. Yeah, so going out to the areas where the farm workers are. Here in the Lower Mainland, there's also farm workers on Vancouver Island, in the Okanagan, that some other organizations are serving to some extent now. But it's really, there's very few other services for them, hence the mobile nature of the program.
Yeah.
In Langley, we've been going there now for over 10 years, probably since 2012 or something like that. We partner with a church that has a mass in Spanish, that they have volunteers that bring migrant workers who want to come to the mass. So they provide the transportation, they provide a huge meal after the mass. So we sort of piggyback on that, use their space, the opportunity that people are already there.
Now, Umbrella also serves the migrant worker community with virtual clinics, usually 1 or 2 evenings a week. Naomi said it used to be a lot of men who used to use their services, but more and more they're actually seeing migrant women and their children join.
Wow, it's amazing that you guys are filling this gap. And so who is it that goes out? Is it a doctor, a nurse, other people? Do they speak Spanish, or do you have translators come in?
Yeah. So almost all of our programs, most of them, are provided through what we call a cross-cultural health broker model.
This is actually one of the reasons I'm here, the cross-cultural health broker model. Umbrella not only offers primary care to migrant workers, they provide care that's pairing traditional primary care professionals with a staff member who's from the same community and speaks the same language as the patient.
So cross-cultural health workers, they're bilingual, bicultural staff members at Umbrella. Most of our health brokers have a background as medical professionals in their home country, but they're not licensed here. So, for example, with the mobile clinic, we have cultural brokers. One is a doctor from Mexico and one is a lawyer from Mexico previously.
Wow.
So they're employed with the clinic. We work with the doctor. We have one doctor who's on staff with us that supports and others that are volunteers.
But Umbrella didn't stop with their mobile clinic model. In 2016, they opened as a family practice to serve more people. They started in the basement of a music school. At the time, they were operating mostly on grants, but by 2019, they were able to secure ongoing provincial funding as a community health center. This funding provided them with security and helped them to expand the clinic services and recruit a whole team of nurses, physicians, and counselors who work on salary. They were actually only the second clinic funded under the community health center model in BC. And that funding, it accounts for about 3/4 of their expenses. They still need to get grants to support the rest. Now, Umbrella serves patients either from their new Westminster location or their mobile clinic.
I can give you a tour. And,
that would be great.
This is Mei-Ling.
We only have 2 clinic rooms. We're quite small. We're not like a St. Mike's size situation yet.
And like with their mobile clinic for migrant farm workers, they brought their cross-cultural health broker model into the clinic, starting with Spanish-speaking brokers and then slowly adding communities over time as needs emerged.
Like with families, strollers, we always work with our cross-cultural health brokers, and they're often in the room.
Here's Naomi again.
So currently we're serving 4 main kind of language groups, although there's a variety of cultures and countries of origin within those. So Arabic-speaking folks from the Middle East primarily, Tigrinya-speaking people from Eritrea, East Africa, Spanish-speaking from Latin America, which includes a subset, so sort of another community of the migrant farm workers from Latin America, and people from Afghanistan, so they might speak Farsi, Dari, or Pashto. Several of those communities have begun being served by Umbrella because there was a crisis and a clear need amongst community members that we were connected with and feeling responsible to, right?
Although Umbrella is now working under BC's Community Health Centre model, the co-op is still the backbone of the organization, which means their decision-making is guided by the community and their needs. To serve the diverse newcomer community, Umbrella understood that it needed to involve community members who could help bridge the language barrier, but also the cultural gap when it came to accessing primary care. Naomi says every patient is assigned a cross-cultural health broker, which they referred internally to as CCHBs. And these brokers, they work as a triad with the patient and the physician, both translating and supporting cultural understanding within the clinical care setting. They also help the patient navigate the system to help with things like booking specialist appointments or getting blood work done or visiting the pharmacy to understand their medications. It's a pretty unique role, one that I haven't actually seen in another clinic, although I know Umbrella is trying to spread the model. And I do think it's one that deserves more attention. Umbrella's clients don't just face cultural and language barriers, though. There are also challenges accessing resources and programs in the community. So in addition to cross-cultural health brokers, Umbrella actually has a separate team dedicated to addressing social issues. In a lot of clinics, this would be the role of social workers, but here, the role is treated a little bit differently. Here's Mei-Ling.
This is just like our social determinants of health team works here. So it's just like kind of a drop-down space. But so we have a couple of workers that we just call them SDH, but they're social determinants of health workers. And they just address social issues. It's amazing. They just solve problems. They're just like, does the baby need formula at the food bank? Go, and they just solve it. Because I think most of our staff is also from the communities that we serve. And so there's just like a different flavor to it, which I really like, because they just tackle things, There's just like not a lot of limits. They're like willing to engage with any problem.
The cross-cultural health brokers, they can handle some social support, but issues related to the social determinants of health, like access to food, housing, settlement issues, they're largely covered by this team. Interestingly, the health brokers actually rotate in and out of this social determinants of health team to try and pick up more expertise that they can bring to their job. Between the family practice and the mobile clinics, Umbrella employs about a dozen cross-cultural health brokers. They also have a team of medical office assistants who Naomi says tend to come from communities they serve. Several speak Spanish, and one also speaks Tigrinya. One of the assistants is a floater and also works with the mobile clinic. The mental health team, it's made up of 2 clinical counselors. One speaks Spanish and the other Farsi. They both have experience working in immigrant and refugee health. The mental health team, they're available for crisis counseling the same or next day, but they also run group sessions and try to connect patients with community resources when they can. Umbrella also has 3 part-time nurses and 3 social determinants of health workers. And there are actually only 3 part-time family doctors, one of which you'll hear from shortly, and 1 part-time nurse practitioner. Together, the family doctors and the nurse practitioner, they only add up to a total of 2 full-time equivalents. That's a small team of doctors and nurse practitioners. They are far outnumbered by the rest of the team. But I'd say that ratio is proportionate to the needs of the communities they serve. Lastly, they also have a few administrative roles, including an executive director, a finance manager, and the director of integrated health services, which, of course, is Naomi's role. I think one thing that struck me, and one of the reasons I've come here, is because Umbrella is an organization that is very responsive and accountable to the community it serves. And I'm wondering how that plays out on a, day-to-day or year-to-year basis.
Yeah.
How does the organization continue to be accountable to community and responsive to the community needs, or even understanding what those community needs are?
So a lot of it we've tried to build into our structure, right? The structure of being a co-op.
By the way, this is Naomi again.
And the vast majority of our staff are also from the same communities that we serve. Again, kind of intentionally through the structure, right? And the models and programs that we use. So staff members are cultural brokers, for example, community health workers are members of the same communities that they're serving. And they're typically leaders in those communities, and they're present day to day, which can be really challenging for them sometimes. So, for example, we have at least monthly meetings of the team where cross-cultural health brokers are asked to kind of describe what trends are they seeing in their community, and then we'll try to brainstorm, is there something that we can do? Sometimes it doesn't feel like there's something that we can do that's a perfect fit, but maybe there's something. So, for example, right now there's a reduction in funding for settlement across the country. There's some programming for families that's closing in the Lower Mainland. We don't have a lot of programming for families, but we have some capacity in the counseling area. Can we offer some kind of mental health counseling paired with parenting that could be supportive and help fill a little bit of the gap that people are experiencing? So constant kind of conversation with community members and internally to try to understand what resources do we have, even if they're not perfect, and how can we get creative to try to do something that helps.
Naomi says one big piece of feedback that they often hear is that community members want to know, how can they become a patient? But Umbrella is unfortunately working at capacity. At the time of my visit in March 2025, they had 2 vacancies for an RN and an NP, which they eventually did fill in September. Naomi says it's important for them to hire doctors and nurses who understand the goals of their unique clinic.
We're a little bit complicated, right? Our structure is very different. Our patients' needs tend to be quite complex, sometimes quite different than what people are used to seeing in other settings. So it really needs to be the right person who joins us. So that's part of it. Cross-cultural health broker capacity is also sometimes a limitation for us, and again, would require more resourcing, more funding.
Despite these challenges, Naomi says they're dedicated to pushing their model forward, growing their teams, and eventually the possibility of serving more communities.
There are obviously many communities that are in need that we're not serving. We do sort of constantly watch what's happening in the world, who's coming to Canada as new populations who are underserved. But we are quite structured in who we provide services to because we really believe in this cultural brokerage model, which means that in order to serve a certain community, we really want to have the staff capacity, the folks working with us that are from that community that can do a really good job of serving them in their first language and supporting the cultural brokering. So we kind of limit to date the number of communities that we serve more than many organizations would, because it's so important for us to have that in-house language and knowledge of those cultures. It likely will continue to evolve, but I don't imagine we would ever move away from that cultural brokerage model.
Yeah.
So it would always kind of follow the process of recognizing that there is a new community that's underserved, scanning who else is serving them, trying to obtain resources so that we could have people working with us from those communities and then beginning to serve them rather than beginning to serve communities and then trying to learn the language or the culture or understand how to serve them well after the fact.
I know you're in the middle of writing a grant,
Yes.
so I don't want to take up too much of your time.
Thank you.
If
It's due at noon.
It's due at noon.
Yeah.
Maybe you won't have time. I don't know. We'll see. Is that clock right?
It's wrong,
No,
but I
it's
do
wrong.
I have a meeting at 11
Okay.
as well. 11 till 12.
At the end of my tour, Naomi had to run to meet a grant application deadline. So Mei-Ling and I got the chance to sit down together and talk about our experience working in this very unique model. Because while Umbrella has a small footprint, it serves a big purpose. And it's a great example of how primary care can be accountable to the communities it serves. Here's that conversation. Tell me a little bit about yourself and what you do and how you ended up here.
Let's see, I've always been kind of interested in immigrant and refugee health. And so when I did my training in Toronto, I worked at a place called Access Alliance.
Oh.
I did my training, my sort of longitudinal family medicine training there. And then when I came out to Vancouver, I worked for a while at a place called the Bridge Clinic, which is also was a refugee clinic, but was closed down by the health authority in 2017. And we had sometimes partnered with Umbrella because Umbrella does longitudinal primary care, whereas the refugee clinic does transitional primary care. And so at that time, they were looking to expand their family practice because they had direction from their board and their community. People in the community really, really wanted to have primary care. So at that time, they were meeting with different family physicians or nurse practitioners to try and build a primary care program. And so they brought me on at that time.
I wanted to also just ask about the governance and funding model for Umbrella.
Yeah.
And because I think you also mentioned that, when it started out, it was actually the doctors were paid fee for service. This is at its core a nonprofit co-op.
Yeah.
And it's providing lots of different services in that structure. So how is it getting its funding and how is it governed?
That's a great question.
And then how does it make the doctor part work?
It's evolved over time. Once we got our funding contract through the Ministry of Health, they gave us some core funding for a few of our positions.
Yeah.
So right now, all of our clinicians are salaried. Everyone is salaried, but our funding comes through the Ministry of Health.
So when you say everyone is salaried, you mean like the doctors, the nurse practitioners, the nurses, the social determinants of health.
Yeah.
Okay, so you've got
CCH, our cross-cultural health brokers, everyone is
on
salaried. Yeah.
And does the Ministry of Health funding pay for all of those roles?
They pay for most of it.
Okay.
I think in terms of the total organization, I think they pay for maybe 85% of the salary and some of the overhead.
Yeah.
And the rest is through grant funding.
So you have staff members here who are applying for grants as part of their job, I assume.
Yeah. Unfortunately, it's often kind of it's not off the side of their desk, but it's kind of everyone plays multiple roles here because that's the only way we can make it work is that, we have people who have like diverse skill sets and they apply them in different places in different ways because, we have to be nimble. That is just the only way that we've managed to survive. But I think it's been very useful for me to understand over time that keeping the core idea really intact and then just being flexible around it is a way to build sustainability. Is that we try different things and when they don't work, we try something else. And I think that flexibility has served us well over time. And it's allowed us to be like a little more creative with how we try to do things. And that has allowed us to come up with like the social determinants of health workers, and just do things that are honestly efficient and practical. That is fundamentally how we roll. We're efficient and practical, but without compromising on the quality of care. Yeah.
And you mentioned keeping that core idea central. What do you think the core idea here is?
Yeah, is it putting the community first? is that this is the care that the community wants and deserves. Mm-hmm. And so we don't compromise on that. Mm-hmm. You know, we always keep that front of mind. Mm-hmm. And then we flex around that. Mm-hmm. Whereas I think sometimes it's easy in these like larger sort of bureaucratic health delivery structures, it's much easier to kind of like let these kind of more grassroots, you know, on the ground programs go when they're making cuts. But then you lose your relationship and you lose your kind of core values around what you're really doing. And I think people feel that. I think that's reflected in our care.
Absolutely. Yeah. I mean, absolutely. I think the 6th-hour care standard is that primary care should be accountable to the communities it serves.
Yeah.
And that was one of the fundamental reasons I wanted to come to visit today, is because I know that this is a clinic that takes really seriously that tenet.
Yeah.
And I know when we've spoken just briefly in the past, you know, I remember we were part of a conversation, a larger conversation, and that there were some colleagues of ours that were maybe skeptical about whether that could work in a primary care center. And I think we're maybe feeling that, you know, if we gave power to the community, what that would mean for us as a physician or a clinician. Yeah. I think that's what I took from that. And I don't know if you remember that conversation, but I wanted to get your thoughts on that, you know, and some of, I think, our professional reluctance to potentially orient our services towards community even further.
Yeah, that is a really interesting question. And I think, I understand where people are coming from when they're reluctant, because when you're looking at something you've never done before, it, of course, you know, your mind goes to all these places where you can think about, oh, I don't want someone telling me what to do or deciding how I practice, or, you know, if they don't like me, can they fire me? You know, like, I think people can kind of go to that place in their mind. Mm-hmm. And I think it kind of gets lost sometimes in our training, because our training is very hierarchical. And in fact, most of the allopathic medical system is pretty hierarchical. Mm-hmm. And so we're used to kind of being in charge and deciding things, you know, for people, but not having people do that to us, you know. And so I think it creates a barrier in our imagination about what's possible. And I think it actually creates conditions for burnout, because you lose that sense of care, both in what you're doing and even for yourself. Because the other thing that we haven't gotten to talk about is what it's like to work as a clinician in this kind of team.
Tell me about that.
Because it feels like a collaboration. It feels like we're all working together towards a shared goal. We might have different ideas about how we can get there, and that's often really rich discussion for us. And we learn a lot about each other in that process and about different communities and their needs. But it always feels like we're working together towards something, and that is really rich. And it keeps people coming to work. It keeps people working here. It's great for retention. Yeah. Because
you believe in what you do. You have purpose.
There's purpose. It's purposeful. It's meaningful. You see the effect. You see how people stabilize when you treat them as whole people, as a part of a community that you are also a part of, you know. And I think that there's a different feeling where it feels just more collaborative than it feels like I'm just a service provider.
Yeah.
And that is a really different mental state, but it's really rich. And I really, really appreciate learning from my colleagues, from, you know, the community through the board or at the general meetings or the other ways that they interface with us about what they see as their needs. Because I can't see the whole thing from where I am. I can see one slice of the whole thing, you know. And I think for me, it just makes sense to hear from people about what they need and then work together with them to try and meet those needs. I feel like, what else am I supposed to be doing? I don't know. It just makes sense to me in a way that is really both simple and profound. Yeah.
You know, I think it has been a tough time to practice in primary care. At the same time, I think sometimes it does us a disservice to focus too much on that, because I think it takes us away then from focusing on the things that actually provide us joy in work, which is, I think, service to the community. That's why so many of us went into medicine to begin with. I wanted to pick up on something you've said a couple of times, just how you guys are really efficient and you try and do a lot with a little. I think it's important for us to kind of put this in the context too, where people are listening and thinking about their own practices. You know, you mentioned that there's maybe 2 FTE, a family doctor and NP, and maybe you're attaching like 1,100 people together, which may feel like not a lot of people actually compared to what another kind of practice might be able to. Plus, then you've got this team. Understood the team is serving more people than that and not just serving the primary care kind of piece. But yeah, like, tell me a little bit more about sort of the efficiency in this model. Like, is this something that we can scale up? Maybe it doesn't need to be scaled up to everything and everybody, because it's also serving a very specific kind of need, because it's also, you know, it's a lot of resource for potentially 1,100 people.
Kind of. I guess it depends on whether or not we care about health equity. And I know that there is a stated belief in that in most of our institutions. But I think the simplest way to explain it is that, you know, in the kind of classical health equity picture that, you know, that slide I'm sure many people have seen, which is the people standing in front of a fence, different sized boxes. We're the big box.
Right. You're trying to provide more services to people who need them to be able to
achieve the same level of health as other people. I think everybody deserves the opportunity to thrive, but not everybody starts at the same place. And so for me, it really should be the opposite question. For me, when people are looking at the way they're delivering healthcare, they should be asking themselves, why are there certain groups of people that continuously have poorer health outcomes? Like, we've been documenting this for decades. At some point, it becomes questionable to me to continue documenting it because it almost normalizes it. It normalizes a practice of not doing anything. It really feels like we are doing very little to meaningfully address inequitable health outcomes. And so I hear this a lot. Like, people are like, well, you see, you know, so few patients. And I guess that's true, but the patients I see genuinely improve. They do get better. They're not just kind of like half scraping along through life, abandoned by almost every system, you know? And one of the things that we do, and the reason that we expend or appear to expend more resource on fewer people, is that we're filling in gaps through the entire system. Like, I'm saving the social system money, other healthcare providers money. I'm saving everybody else's budget by taking on some of that work. And that's kind of what primary care is supposed to do, is take people who are complicated or just regular people and help them get what they need and then appropriately use acute care when they need it. But that's not what's happening in reality now. But it happens more in this type of service. And I think, yes, we are working with a specific population that is highly marginalized. But to be perfectly honest, I actually think everybody deserves some level of care like this, where they feel cared for and a part of something. I think everybody deserves that. I really do.
I mean, I think when I've reflected on health equity, I think I've also reflected on how people's access to cultural capital is really different, right? And so I think partly what you're trying to do here is, you know, provide people with more cultural capital to be able to support themselves, to be well. Some people in our society don't need that. And because, you know, people like you and me, we can navigate and find a lab and make our appointments and know how to get through, right? And as do many people, actually, but the people you serve don't. And so I think it's important for us to kind of think about that in that broader light. The other thing that I wanted to reflect on today, too, was just the Our Care Standard number 5 a little bit, which is this idea that people deserve culturally safe care that meets all their needs.
delivered from a workforce that reflects the diversity of the community it serves. Because I think what I'm hearing from you today is just how much of the workforce here at Umbrella Multicultural Co-op actually reflects the diversity of the community you serve, and how important that is and integral to the success of the primary care services and the primary health care services, the public health promotion type of services that you do. Yeah, and I wondered if you were able to reflect a little bit more on that.
Yeah, that has actually been a learning for me. I think there's something about cultural safety in theory that we hear a lot about. And there's something different about when you see it in practice. As, you know, the youth say, it just hits different. There is something different about being able to feel recognized in the space you're in. And I think for so many people who come here for so many different reasons, it can be really profoundly alienating. And also, you know, so much of the way our social setting is structured is people get a really clear message, like, this isn't for you. So then to come into a place where it is for you, it just is a different feeling of belonging. And I think that is something that people both crave and deserve. And I think given this, you know, our country's history of using culture as like a tool of oppression, especially for Indigenous people here, it speaks to the power of culture in both sustaining people's communities, sustaining their lives, sustaining their, you know, existences, and, you know, as groups and as communities. And so I think it shouldn't be underestimated. I think there's a lot of talk about it, but there's not a lot of doing. And I think that really needs to shift. Yeah.
And a very pragmatic piece, you know, that we heard again and again in the Our Care roundtables was actually around language accessibility. I think, you know, I should mention, so we did this Our Care roundtable with you guys in 2023, and it was amazing that it was actually simultaneously translated, I think, in 5 languages. So we had English, but Arabic, Spanish, Tigrinya, and Dari Farsi. Yeah. I mean, it was a complicated undertaking, eventually successful, but, you know, it speaks to the importance of language if we want to build something that is truly inclusive and serving people.
It's really basic.
It's very basic.
Everyone should just be able to communicate.
Yeah, I agree.
I mean, that is just so basic.
It is very basic.
It is not actually done. And I think that's the thing too, where, you know, these things need to be built into our health delivery. Because, you know, like you said, it's complicated. It requires a little bit of practice. You know, it's not that easy to throw together for the first time. But then once you've done it, you kind of know a little bit more, and you can do it again, and then you get a little bit better about it. And then soon enough, it's just how you do things. And so when you design services that are just for like one group of people, and then you try to tack on one thing, it's frictiony. It's hard because everyone's working in a system that kind of nudges them to do one thing, and then they're just trying to throw on one extra thing, like just get an interpreter. But nothing about our system is sort of designed to incorporate that. And so everyone's like time pressured, and they think it takes too much time. And we've seen so many mistakes happen just with that. You know?
I mean, I'm lucky to work in a center where we use a language line. And to be honest, that's a very efficient way of doing it. It doesn't take any pre-planning. At least for me, I know our institution does pay for the language line, but you know, in a matter of minutes or sometimes 30 seconds, you can provide have someone on the phone there that can interpret. I mean, I wonder if there, you know, if you think back to the roundtable, are there any other recommendations from the roundtable that you know, that stick with you still, or reflections from what you heard that day?
I think just the requests that people have are very straightforward.
Yeah.
They just want care that really is care, that is accessible to them and that considers them in their like wholeness.
Yeah.
And that is entirely attainable.
It is.
It really is.
I know.
And I reflect on that a lot because I think sometimes, you know, when these conversations happen without like actual community members at the table, and it happens in, you know, these, you know, at levels of administrators or bureaucrats, or I think, you know, they think, oh, people are asking for so much. And they never are. They're always asking for basic humanity, you know? And it's like, so I think I reflect on that a lot when people kind of talk, like when I explain what we do and then people say, that is so much. I just think, is it? Is it really that much? Or is it just care, like fully realized?
Yeah.
Which we haven't seen very much before.
I mean, I think it's also, as you said before, it's care that's grounded in the needs of the community.
Yeah.
So you're listening to what it is that people want and using that as your North Star, right? And I think that all too often we move away from that, actually. Yeah. And so, you know, that was our attempt at Our Care, is to try and bring that North Star back for folks. You know, when I go back to reflect on Standard 5 about the diversity, you know, of the workforce, one thing that we heard again and again actually from Our Care participants was how we need to do a better job integrating internationally trained health professionals. And one thing I noticed was that Naomi mentioned that your cross-cultural health brokers, that many of them actually are foreign trained physicians or health professionals from another country who can't qualify or practice here.
Yeah.
And it really struck me as a nice example of how, you know, ideally we do integrate them here in a professional way where they can practice this, you know, how they did in the country they came from. But if not, you know, this is an interesting model. Yeah. And I wonder if you could speak a bit more to like, how do you train, you know?
Oh yeah,
how do you train the cross-cultural? How do you find them? How do you train them? And then how do you integrate them? Because I think if your staff are coming from like 5 different cultural communities, right, or more, you know, that must cause also some cultural friction. And how do you deal with that?
Yeah, that's a really good question. I think we train people over a long period of time. We have them kind of initially rotate through some of the different programs like social determinants of health, just to kind of get a flavor for what those programs do. And then, you know, they do some observation. You know, it's a slow onboarding. We find people the way we do everything, like through the community, you know, because these are people who are part of larger networks who know each other. And so when we're looking for people, we put out the word through all those channels. Yeah. And then people find us in those ways. We have a fairly intensive interview that asks a lot of different questions around how people understand social determinants and barriers to health access and how they problem solve and how they work through conflict, because those are all very real for any team. You know, any team is going to have some level of just friction and conflict because that's natural for humans. And we've started to invest more over time in kind of team building. So we've gotten grants that allowed us to do kind of like workshops and training on just communication and kind of like working through our values to understand what parts of our values are really our shared values. And we return to that in our conversation. We're trying to get better at doing sort of, I don't know, kind of like quality improvement, collecting some data and using that to inform some of our decision making, or trying to even understand how data collection looks or applies in our setting. So those are all pieces that we use to kind of help us construct our identity as a team, and then decide like, how do we want to work together in a way that's consistent with our core shared values. And yeah, sometimes people disagree on things, and sometimes we've had to learn like that different cultures express themselves in different ways, and even with different tones or different affect, and we've had to do some learning about each other's cultures, which in the end has been really rich. I think people enjoy that a lot. Anytime we have kind of like a fun conversation, even sometimes about like, well, Mother's Day is celebrated on different days and like all these different places and what that means and how that looks. Just little things like that can help us kind of build bridges with each other. And so it does take, I would say, a good 6 months maybe for a new cross-cultural health broker to really settle into the team. Yeah.
Yes, that's a process and a commitment.
Yeah.
Just as we close out, I wanted to ask you, do you have any stories that you might want to share, or a story that you might want to share of a patient or family or community member that has been served?
I think there's two different ones. I think one is a patient who had to overcome a very difficult trauma, and just by being able to come and slowly be allowed to just be heard over time, we're always really clear with people. And I think this is so foundational to primary care, is that we will not abandon you. We are here with you, walking alongside you for as long as you wish. We won't leave you. And so that we can take the time to work through this together, and that sort of steady, compassionate accompaniment, I think, is just enormous for people. And we slowly pulled on all of our different expertises. I used my medical knowledge to support, like I said, medication. We used the social determinants of health to really support income, some immigration, family reunification. Family separation is one of the biggest in our practice. One of the biggest
that myself with some patients who came as refugees.
Yeah, really, really hard. It's a huge determinant of mental health, and also we have learned that if we apply ourselves with a lot of rigor and dedication, we can often push to have families reunified, and that is magnificent. There's nothing like that, to see someone suffering from separation and then have their family brought back to be whole again. And, we had social determinants of health find like housing when, kids were having experiencing racism at school. We were able to address that with the school and the school board. Just understanding people as they exist in their community and as people. This person is now themselves an advocate, somebody that people go to for help, who is seen as established and who knows things about how to navigate the system. And, and she often tells us that the relationship with Umbrella was really foundational in her being able to make room for her to kind of step into that empowerment. And that is like primary care for me in a real way.
Yeah.
And then just recently we've had a case where, we often do get referrals from like the Children's Hospital or acute care settings when they see someone has like immigration related complexity and they're just like, I don't know, you take it, And so we've had one recently where, a parent with a sick child was experiencing a lot of difficulty communicating with the team, even though they were using an interpreter. Things just were not getting across, and she was feeling really distraught because she was feeling quite judged as a parent. And that was something where she was able to bring that up to us with the cross-cultural health broker in a way that she just felt free to be able to say. I mean, she was very distraught, but just felt free to be able to explain that. And then we were able to go back to the acute care team and say, hey, did you know this was happening? And we actually had our team members attend some of the appointments subsequently. And then it was really funny after that, because then after that, the acute care team, because this is a child who needs ongoing care at that level, they were like, can you actually have your team member attend all the appointments? Like, they were like, please come all the time. And now they're like emailing us all the time, did you know that this happened? Which is great. It's the kind of collaboration we want. And we approached it, not to say like, hey, your care has been bad, but there's just been a mismatch and some miscommunication. We're here to help. They were totally stunned. They had not experienced a primary care team reaching out like that or structured the way we are. So there was a little bit of, we explain who we are.
Yeah.
And then we've developed this collaborative relationship now, and the patient feels so supported. And now they can move forward with part of their care that they were withholding because they weren't sure that the family could handle it.
Wow.
Yeah. So I think, these are things that are really impactful. And this is that big box work that is like unseen in so much of the data and other, and the resourcing, but that's what it is.
Yeah.
Yeah.
Those are great stories.
It's good work. I really like coming to work. Yeah.
Anything else you want to say as we close out, Mei-Ling?
I think I'll just comment on that one piece that I really enjoy coming to work. And I feel really lucky, I think, in the healthcare landscape right now to have that. And, it's not an accident. It's like a series of deliberate choices that our team has made. But the team, in the same way that it cares about the patients, it care about each other. And so that piece has also been an important learning for me, so that same lens is applied. People on our team are humans too. They've had their own health challenges. They've had family health issues, all the things. And when they've needed to take time off, they just get the time off. And we flex around it. We adjust to support that. And that means that people feel able to also take care of themselves. Mm-hmm. And I think that is really huge. And that is really going to contribute to our sustainability over time as well. Yeah.
That's lovely. Thanks for having me here.
Yeah, thanks for coming. That was really fun.
To me, Umbrella exemplifies how primary care can be accountable to the communities it serves. In this case, a historically underserved community. When I think about it, the best models I've seen of primary care serving the community have actually been developed directly by community members themselves. And in the case of Umbrella, those primary care services, they actually arose from the cooperative advocating for those services to exist. And then through hard work and persistence, the team was able to build a model that eventually was funded by the province. The role of the cross-cultural health broker, it's unique, and I'd love to see aspects of that integrated into primary care clinics serving newcomer communities across Canada. I recognize, though, that there's limited dollars in primary care, but I do think more of that money needs to go to supporting people who have historically struggled the most. And as we talked about in our Costa Rica episode, one of the challenges is that our primary care funding and public health funding are siloed. And so when we see gains because of prevention, the same ministry is not necessarily reaping the rewards. But most of all, when I reflect on the visit we just had, I would love to see other clinics embrace the kind of community governance and accountability exemplified by the Umbrella model. I think it's the best way of ensuring that the services we design are truly meeting the needs of patients and communities. A huge thank you to Naomi and Mei-Ling for welcoming me to the Umbrella Multicultural Co-op. For more information on Umbrella and to see photos from my trip to the clinic, head to the link in the show notes or primaryfocus.substack.com. Now, while Umbrella gets some funding from the BC government, it still relies on grants and donations. So if you're interested in donating to Umbrella, head to our show notes for more details. I know they'd appreciate it. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by funding from the MAP Center for Urban Health Solutions, St. Michael's Foundation, and the Max Bell Foundation. Miriam Dinash is our research assistant, Seema Marwaha and Emily Holton are our creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. Family doctors in Canada who are listening to this episode can claim MainPro credits by completing a linking learning exercise. See the show notes for more information. And finally, if you're enjoying this podcast, I hope you'll share it in your networks. It's only through enlarging the conversation about primary care in this country that we're ever really going to affect system change. And if you have cool ideas for topics or places I can visit and feature in our podcast, please do reach out at primary.focus@unityhealth.to. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. Views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.